Welcome. Happy that everyone is here. I was just told that I could tell a few jokes, but I think you'll all be happy to know that I didn't prepare any jokes, and so that's a good thing. But the way we're going to proceed here is we're going to have a brief introduction or overview of the ACA by Mr. McHugh, and then after that, each of the panelists will be able to give a 2-minute sort of opening statements from their perspective of the ACA, and then we'll go into some questions and answers of each of the panelists. So, Mr. McHugh, if you would like to start, please.
Sure. Thank you. I think I found the only city other than Washington that's really hot today, so I really appreciate that. Actually, what I'm going to try to do in the time I have is give you an overview of the recent decision by the Supreme Court, what it means to the ACA, what it means to all of us, whether we be employers, providers, insurance companies, or just people who might be otherwise covered by these plans. I'm told that what usually takes me about an hour to go through, I have 8 minutes to do it. I was aware the other day in London that they pulled Bruce Springsteen off the stage when his time was finished, so I'm under no illusion that I'm going to go longer than 8 minutes. So let's go a little history of what happened. The law was passed in March of 2010, March 23rd. I'm sure you all have anniversary parties every year since then. Immediately thereafter, a bunch of lawsuits were filed by a bunch of different players, whether they be individuals in some cases, but most importantly by states. 26 different states filed a lawsuit based in Florida. And that lawsuit eventually filtered its way up to the Supreme Court, where this spring, I think March of this year, right around the actually anniversary of the passage of the bill, we had hearings over 3 days in Washington on the bill and whether the bill should pass muster according to the views of the Supreme Court, the final judges on this issue. There were 4 issues in front of the judges at that time. The first of which was the constitutionality of the individual mandate. The whole law, really the guts of the law, is this rule that indicates that most Americans, there are some exceptions, but most Americans have to get coverage for themselves one way or the other, whether through an employer or whether through an exchange, or somehow or another they have to have individual coverage. Was that provision constitutional? A second question, which ultimately became moot, was whether if that provision is not constitutional, can it be severed from the rest of the bill and the rest of the bill saved? Or if it's not constitutional, does the whole bill go into the trash, essentially? The third issue, which was an issue only tax lawyers probably could love, and most of us really didn't love it that much either, but was the Anti-Injunction Act issue, which basically asked the question whether anybody could challenge the bill or challenge the penalty associated with the individual mandate prior to when it actually first gets imposed and you have to start paying the penalties. And as you may know, those penalties aren't applicable until 2014 and thereafter, so the issue there was essentially whether this challenge was really too soon, and you had to wait. The fourth issue, and the one that everybody thought was a bit of a yawner, at least at the time, was the expansion of Medicaid, which was in the bill, whereby Congress decided to expand Medicaid to cover people previously not eligible for Medicaid as a way to kind of fill that gap of the 30 or 40 million, you hear different numbers of people out there that didn't have coverage, whether that was a problem. Many of us thought that was not a very big issue. Turned out to be probably the biggest issue in the case in terms of its future implications. The intelligence in Washington, and those are 2 words you rarely hear in the same sentence, was that the mandate would survive, at least prior to the arguments in front of the court. There were pundits all over Washington, I'm sure here too, basically saying 2 things. It will survive, and don't get very serious about what goes on in the oral arguments because you can't judge anything by the oral arguments. The day after the last oral argument on this thing, those very same pundits were in the news everywhere telling everybody what was going to happen based on what the oral arguments did, and they were essentially all wrong in what they predicted because at that time, after the oral arguments, all those so-called pundits who knew what they were talking about thought the court would throw the whole thing out based on how the arguments went. That's not what happened. So what did happen? The Supreme Court, I guess, surprised a lot of people in what they did, and especially by whom the opinion was written, but essentially the result is the bill survives. The bill survives almost in total, in fact, based on the opinion of the court. That's the big news. The surprising news is that a portion of the bill, the Medicaid expansion became the most interesting and, I think, difficult thing to handle as far as this thing is going forward. So how did we get there? First off, maybe the first surprising thing is the majority opinion in the case was written by Chief Justice Roberts. Nobody thought that was likely. Most likely people thought Justice Kennedy, who typically is a swing justice on the court, would be the one who would sort of come down one way or the other and decide this thing. Chief Justice Roberts writing it was a great surprise. There's at least one person, me, who actually won bets because predicting that would happen, so I was frankly very, very pleased by that. But he wrote the opinion, and he essentially saved the bill based on the reasoning of his opinion, joined by 4 other justices in various parts of the opinion anyway. So let's dissect very quickly what the portions of the opinion did. The first decision that Justice Roberts announced, and those of you who may have heard this, you may have seen that Fox News, CNN, and all these different news programs initially came out with faulty information. They initially said that the mandate was tossed out by the court, and it was all over the news. It was kind of embarrassing because it turned out not to be right. The reasoning for that, or the reason for that, is the order in which the judges announced their decision. They started with the Anti-Injunction Act. The Anti-Injunction Act, again, was this provision that said it might be premature to hear this. The judges rejected that argument, and the reason for rejecting it is kind of interesting. They rejected it because within the bill, the penalty for not getting individual coverage is labeled a penalty. It's not labeled a tax. And the justices said when Congress wrote the Anti-Injunction Act, they used the word tax. Congress should know what they're talking about. That's a debatable point. But they should know what they're doing, and they called it a tax, and they said this relates to taxes. It doesn't relate to penalties then, according to the judges. And so they threw the Anti-Injunction Act argument out the door. That's the first thing the reporters heard as they were getting ready to tell you what happened in the court. The second thing the court did is turn to the Commerce Clause issue. There was a theory in the case that indicated that the Commerce Clause, which gives Congress the power to regulate commerce in this country, generally considered quite broad, if you read Supreme Court decisions over the years, that the Commerce Clause was broad enough to give Congress the right to regulate the industry, the healthcare industry, in the way they did. That is, imposed a mandate. There was a lot of debate about that. This particular court, led by Chief Justice Roberts, wrote that it did not. They concluded that although Congress has the right to regulate commerce, they do not have the right to create commerce. And in their view, that's what was going on here. And if you would allow Congress to get into this area, you probably all heard about the broccoli argument that was all over the news. If they allowed them to get into this area and do what they wanted to do here, based on the Commerce Clause anyway, there would be no effective limitation on what they could do. So a good way to put it, and the way I've been putting it, is this has been a big win for broccoli haters. So you can all rest easy if you're one of those. Then the court threw a curve, pretty interesting curve. At that point, by the way, this is when the CNN and Fox and all those people went out to the networks and said the mandate was dismissed, because they didn't anticipate what was coming next. And what was coming next, as Chief Justice Roberts announced the opinion, was he got to the tax authority issue. This is the issue that asked whether within the taxing authority of Congress, which is another provision in the Constitution, whether this was within their jurisdiction to impose taxes. This was a fairly debatable issue as it went through. In fact, it wasn't considered a very important decision issued by the government. There were rumors in Washington that they were about to drop this argument in their briefs before it ever got to the court. And the only reason it stayed in is the Solicitor General, Don Verrilli, was able to convince him to leave it in. Had he left it out, things might have turned out a whole lot differently. But in this case, Chief Justice Roberts said basically two things. He said, Supreme Court has a duty. If it can save legislation, it should save it. If it can come up with some colorable argument to save, it should. This was a colorable argument in his opinion, and what he basically said was, this thing operates like a tax. We're not calling it a tax, but it operates as if it is one. That's close enough. If it acts like a tax, it is a tax, or it's close enough to being a tax that we're going to save it. It's a very interesting sleight of hand. Some people have called it judicial sleight of hand. Justice Scalia, in the opinion, called it, I think, verbal wizardry. But basically, it comes down to this. As far as the Supreme Court is concerned, when you're dealing with a piece of legislation, the Anti-Injunction Act, labels count. Labels are very important. If they say they're going to address taxes, they're addressing taxes. When you're dealing with the Constitution, labels don't really mean anything. The question is whether the Congress has the ability to do something, and it doesn't matter what Congress calls it when they're doing it. To Chief Justice Robert and the other judges that agree with him in this, that was a huge distinction, and that's what won the day. So at the end of the day, based on the taxing authority, the individual mandate was saved, and with it, the entire piece of legislation, or almost the entire piece of legislation. Significant development, historic development, and I guess we'll see where it goes from here. The almost part is what I want to end with, and that's the last issue in front of the judges, which was the Medicaid expansion. There was a provision in the bill that's designed to provide additional Medicaid expansion to cover roughly half of the people that we thought were not covered in this country. Estimates of 15 to 17 million people would be covered by this, and that would allow those folks to be covered by state Medicaid programs through this expansion. The first question in front of the judges was whether or not Congress could do that. Could they even expand Medicaid that way? And the answer to that was pretty quickly yes. Second question was, did they have authority to coerce the states to adopt the Medicaid expansion? And the way, maybe I shouldn't use the word coerce, that was a word used in the case, but the way Congress was enticing states to do this was by telling them if they didn't agree to the expansion, they would lose all their other money previously provided to them for Medicaid, period. Huge issue. Congress was basically saying you take all or none. The rule enforced by the court in this case was that's coercive, you can't do that. If you read the opinion, the term Chief Justice Roberts uses is you can't put a gun to their head. And they said in that context, you can't force the states to adopt the expansion if by that they lose all the other money they have. So where are we? The law survives. For employers, employers have to deal with it pretty much the day before as they did the day after in terms of how they have to deal with the law. Providers, insurance companies, I think the same thing. States have a lot more issues to deal with now. They have a lot more flexibility than they had before, which is going to bring politics into the game as well. States can now decide whether they want to have Medicaid expansion or not. What are the ramifications, political, economic, to do that? Along with the decision they already had to make, which do they want to establish an exchange? States are going through these issues now of whether these exchanges that the law requires them to do, whether they really want to progress one. So now they have two big issues to deal with, and they're going to have to decide. I think, and I'll get off with this comment, the biggest development here is that we've really changed the equation as to giving the states more power here, and much more power than they had the day before the opinion went down. And I think what that's going to lead to is both delay. I think there's a realistic chance that some of these issues, some of these timelines will be delayed because of this, and much more flexibility given to the states as to how to implement this. If you heard in the news over the last weekend, I don't know how many of them, but all the governors met in Williamsburg in my state of Virginia, my home state of Virginia, to have a meeting. And one of the things they decided is if we're gonna have to do this expansion, by God, we're gonna get something in return from it, from the federal government. We want changes, and we don't want the changes just to relate to the expanded Medicaid. We want changes to relate to the entire Medicaid program. So we're going to see states coming at the federal government with a vengeance, I think, and the Supreme Court has given them that power that they didn't have before to come after them with that vengeance. So I could talk a whole lot more, but I think I can't. So that, in a nutshell, is what happened with the opinion.
I think you thought I was about to pull the plug. I wasn't going to do that to you, though. You know, despite the significance and the relevance of this law and the landmarks Supreme Court decision that followed, there are still a lot of Americans who do not know what is in this law, what the law will do. They could tell you quite a bit or have an opinion about the politics involved in it, and they blame the media for that. So, but you know, there's obviously a lot to the law that needs to be discussed that people need to have a greater understanding of, and that's what our panelists are here to do today. So I'm going to direct questions to individual panelists, but hopefully the others will feel free to jump in as well. So I'll start by asking Dr. Vanderhoff. You know, among other things, the ACA cuts reimbursement rates for hospitals to pay for the additional number of people who are coming into the healthcare system. And this is done in part also to try to nudge or offer some incentive for the healthcare industry to begin to work together to come up with new payment systems, maybe add value over volume, et cetera. Can you talk a little bit about how this new law is actually going to expedite that, or it's going to push that forward if it's not already being done?
Yeah, interestingly, I think the most substantial thing that we see coming out of this law is a substantial move to increase accessibility. But there is some fundamental work related to alignment of incentives among payers, providers, and patients that really has yet to be completed. Looking at this legislation and thinking about how to approach the future, Ohio Health, and I think many other healthcare organizations, have not limited our thinking to, well, what's in the legislation or what might the court do? Rather, I think we've looked ahead and said, what is the cogent vision of the future for healthcare that might help us address these challenging issues? And for us, I think it really has been the value equation that Reggie has referenced. Value for us really defined as the highest quality of care we can deliver, the best caring, the best care experience that we can deliver, access, and affordability. And getting from where we are now to there really requires transformational change to what we're doing, because the simple fact of the matter is this: our healthcare delivery and payment system is built on a very antiquated model. It is built on a model that really is born of a day when a single physician working with a single patient at the point of care could deliver most of what that patient needed. Physicians were trained in that era and that way of thinking as expert craftsmen, and we paid them as expert craftsmen by the job. And to use a term from Atul Gawande, and we paid them more if the job was daring. Now, the problem is that's not how medicine is practiced today. It takes a team effort to deliver effective, comprehensive care today. And that team extends beyond hospitals and physicians to include payers, providers, policymakers, and the patient. Now, I'll tell you, what we're doing today to try to address that issue is creating the value-driven scenario now. So Ohio Health is partnering with the Medical Group of Ohio, creating a clinically integrated product that has been externally described as an accountable care organization called Health4. Health4's goal is that value equation that we talked about, and innovative insurers like Medical Mutual have partnered with us on trying to make Health4 real and realize that value destination that you referenced.
Mr. Lauderjohn, maybe you could follow up on that just to talk a little bit about how the business model for healthcare insurers, if you will, is being forced to change, if that is in fact the case, as you try to be a partner along with others in trying to change the system.
Sure. Thank you. The marketplace is changing really rapidly, and if there's one thing that you would want to credit the debate and the discussion and the law, the healthcare reform law, that's the acceleration of this change. We've gone through a period of about a decade or two where we've had fee-for-service reimbursement, where we've paid for volume. And it was a convenient way of doing it, and a convenient way of measuring it was our customers or our employer groups would measure our health plan's level of success by the amount of discount that they offered. And we could actually demonstrate a higher level discount by delivering more services, but we've had a need to get away from the price equation to get to the cost equation. And the cost equation is a function of both price and utilization. What we've been working on, there's a very key cliche within our industry that healthcare is local, right? And it's very true in Ohio. There's different degrees of readiness and organization and strengths and weaknesses within any delivery system within a marketplace. And so Medical Mutual, in the different markets that we serve, we look for opportunities to better cooperate and collaborate and integrate, if you will, with delivery systems that are innovative and recognize that the way we're doing business, paying fee for service and fee for volume, is not the most effective way to move forward. So we know what's driving the cost of healthcare. It's chronic diseases. It's the fast pace of technology that that we would pay on behalf of an employer group to a provider because the doctor orders it. We know within the industry that specialty pharmacy is driving it, driving our cost. The way that we've dealt with them in the past is come up with a program to review claims and perhaps deny them if it's not what the evidence-based medicine might say is the most effective progression of services, or we may negotiate for lower fees. So if we negotiate for lower fees, we focus on a couple of things. What's happened to us is where we may have agreed to lower fees in one area, then we see cost rising in another area, and it's this cat and mouse game that's happened over the years, that where we might focus on what the current problem is, other issues arise. So what we are working on at Medical Mutual, and I know that many other health plans are, is looking for opportunities to address what we know are high cost, chronic disease, specialty pharmacy, technology, and work to lower those costs, but also focus on the larger population and structure our reimbursement such that if we can cooperate and collaborate, if you will, to lower the cost while we're paying attention to metrics that demonstrate that we're also improving the quality on those things, and we're taking a more holistic population approach and making sure that while we're working on these things, we're tending to all the other things that might pop up, that we can really work to achieve a term that, if you haven't heard already, you're likely to hear more often, and it is sort of born out of the ACA, and that's the triple aim. We're working to improve the health of our members. We're working to do that through improving the healthcare delivery model, and I'm fortunate enough to work with over 300 clinical folks within our organization and collaborating with some terrific providers around the state of Ohio. So if we can improve the health through improving the healthcare delivery system, then we can achieve the third aim of lowering costs.
Mr. Beal, I know that you, in particular, are concerned about the consumers, the individuals, and their stake in all of this. With, approximately 17, 18 million more people coming into the system, many of them through Medicaid, we know already that there is a shortage of physicians who are willing to accept Medicaid patients right now. How do we address that problem, and does the ACA do anything to encourage more physicians to accept Medicaid?
Thanks. Couple of comments. I tend to think that in all the political noise that we're all trying to either digest or avoid, that we kind of lose sight of the fact that the Affordable Care Act is what I call it's the first station on a journey of transformation. It's not the destination. And I think there's way too much that gets laid on top of the ACA as if when this thing's implemented in 2014 through 16 or 17 that you know, all the fundamentals that other panelists have spoke to are going to be solved. So, you know, to get to your question, I think we have to view change through a longer lens than a couple of years. And if you look at, you know, physician access or service access in a couple of year frame, it's going to be ugly. You know, when we think about in the state of Ohio, the projections are about 900,000 Ohioans would be enrolled in Medicaid. That's almost 1 million people coming into a system right now that suffers from access issues. If you look at a lens with a little bit broader frame, there's a lot of provisions in the Affordable Care Act, as well as other legislation at federal and state levels, that are starting to get serious about, you know, workforce and changing incentive models and medical education. We were talking before, I mean, we're going to be blessed here with another medical school locally that is really geared towards primary care. But I also think we place too much emphasis on the physician. No disrespect to the one sitting next to me or those of you in the room. But we're really starting to get serious in this country about shifting to a team-based delivery system. Some people call that everybody practicing at the top of their license. And physicians are an important part of the team, but they're not the team. There are lots of other members of delivery systems in with different licenses that can be doing a lot more than what we're asking them to do right now. I'll give you a good example. Practices, I do a lot of work in primary care, but I think the lessons learned can be applied to other settings of care. You know, in primary care, we can have nurses doing better care coordination of patients with chronic conditions. The Affordable Care Act has demonstration projects in it around Medicare, Medicaid, and commercial plans are also collaborating around building different kinds of incentives for us to test different models in primary care that are team-based. So I don't sit here thinking that we're going to grow. Do the math. 1.5 million Ohioans potentially could be enrolled. We would have to find about 750 primary care providers in the next couple of years. That's probably not going to happen. But if we look about the promising changes that are happening, and I think the Affordable Care Act has been a nice trigger. It hasn't necessarily been the only thing that's bringing about change, but I like to, people throw around this word transformation pretty loosely. And if you look at the definition of transformation, it's creative destruction. Think about those words. Healthcare is a laggard. We're a dinosaur. How many people are in banking in here? Think about banking 5, 10 years ago and look at banking now. A lot of change. Healthcare is going to go through a lot of change, and one of the things that a lot of futurists think is we have to let consumerism go wild in healthcare. It is time, and employers are doing this, health plans are doing this, and providers are doing this. We've got to look at consumers being a much more active role, both financially as well as decision-making in this, so that we're not just looking at physicians as solving these problems. I think we will fail if we look at it through kind of that traditional model that we've looked at for years.
Dr. Van Hoff, do you care to follow up on that? I know that you had
I think
shared
that
some concerns
I
on
think
that.
there's a lot of resonance with me in Jeff's comments. So first, let me comment on the journey. I agree with him. The healthcare reform legislation that we have was a discrete event that is part of a much longer journey. I also agree with him that I think that the destination for that journey is a healthcare system that is characterized by value. And I think that that value does include the elements that he and I have been referencing, those elements of quality and accessibility and affordability. But as he aptly pointed out, the model going forward is a team-based model. And those team-based models are developing even now and will develop further in the future at multiple levels. There is the direct healthcare provider team, now made up of physicians and other care providers working with physicians to deliver that care. Increasing collaboration between physicians in various venues and hospitals and extended care facilities, et cetera. And then more and more between healthcare, the healthcare providers, and those outside of healthcare, policymakers, payers, and others who have a stake in the game, the employer community, increasingly engaged in helping to move through all of this. So that all makes very good sense to me. I will comment, though, briefly on the issue of physician shortage. Even as we make this transformational change to a more team-based approach to care, there is simply no question that we are facing a dramatic and potentially dire shortage of physicians in this country. The AAMC has pointed out, and it's the Association of American Medical Colleges, they've pointed out that, hey, you know what? Every day for the next 19 years, 10,000 people are going to turn 65. Their estimates are that 90,000 physicians will be the shortage number by about the year 2020. Now, let's say that they're wrong by half. We still have a dramatic shortage that is looming in front of us. And so I think efforts like we're undertaking here in this community to expand medical education. We've been fortunate to have philanthropic support and community and support from Ohio Health, Ohio University, and other organizations. That's great. But at the end of the day, we're not going to be able to expand that education as well as the education of other providers without considerable public investment in that part of the pipeline.
Mm-hmm. Did you want to jump in there?
Sure. The team-based approach and the expansion of services and alternative delivery models, it can be really important. The challenge, as a health plan, we're consumer advocates, and we work on behalf of our members to help maximize their benefits. One of the challenges we have is this is confusing. And when a health plan or a minute clinic or a worksite wellness program is not well coordinated with the physician, it can be very confusing for the member. So efforts at the community level, at the health plan level, at the delivery system level, to better coordinate these efforts and minimize the confusion is what can help our members, help all of us best access the right care at the right time.
You know, and at some point, as we move forward with this team-based model, the alternative options and things that you're discussing, Ohio is going to have a healthcare exchange. And so the issue is whether or not the state is going to set it up or whether the federal government is going to come in and set it up. I would like for each of the panelists to maybe just comment on the pros and cons of, right now, Ohio is leaning towards allowing the federal government to come in and set it up. Are there pros and cons of allowing the federal government to set up a state-based exchange program? Mr. Bill, you start.
Gee, thanks. You know, I think I'll take your question and augment it a little bit, just because I don't think we really know the answer to those questions. We don't have these things yet. So I could probably use our scarce time going up and down the pros and cons list. I would share this. Regardless of who runs the exchange, we've got to get serious about establishing a navigator strategy. What Kevin said is true. Most people know more about their cell phones than healthcare. No doubt about it. And we're talking about a brand new mechanism for enrolling in healthcare, especially for a huge population of people who have been chronically uninsured and are distrustful of systems of care. So, you know, one of the things that is embedded in the ACA is for states to use not just federal funding, but best practices to build community-based navigators. And I think that if we fall victim to build it, they will come, we'll have a panel here in about a year talking about how only 10,000 people signed up through the exchange in the first 6 months, which I don't think any of us want. So I think there's a lot of community level engagement that we need to do regardless of who runs the exchange. That might be easier to do if it was a state-run exchange. Sure. Versus a federal exchange. Some of that's going to be determined by how much of a cookie cutter the feds use. If the feds come in and say this is the way it's going to work everywhere, black and white, this is it, then that could be quite a challenge for us to reach out and engage stakeholders.
Kevin referenced the saying that healthcare is local. And what is so true about that is that it is a local community that understands best the needs and the dynamics of its healthcare environment. And honestly, I think it would be a mistake for us not to proceed in the creation of exchanges in a way that ensured the voices of those who are going to be most impacted by and who will do the most to make those exchanges a success or failure are engaged in helping to design them. And I don't see how that can really happen if we are not at the state level engaged in trying to develop and influence how those exchanges look. I think the employers in our state, those in the healthcare industry, whether they're payers or providers, and I think our patients, the people of Ohio, need to have an active voice in helping to craft what our exchange looks like.
So I was driving in this morning, and I knew this question was going to come up, and I don't want to outrun my coverage here. It's not what I think about or come to work thinking about in the morning. It's what's the saying? It's not my job. I work on every day trying to figure out how to improve health and make healthcare affordable, and that's what we need to stay focused on. I do know that a lot of the rules around exchanges and other aspects of the reform law have yet to be written. So you can do some prudent things to prepare, but it's very difficult to structure yourself or orient yourself for something that, whether it is going to be the state or whether it is going to be the feds that are establishing the exchanges, it's a difficult thing to plan for and prepare for. We think that our customers are best served, and ultimately our policyholders who own our company are best served by us, by me in particular, and the folks that I work with staying focused on trying to improve health, improve healthcare, and lower costs.
Sure.
Can I add
Sure,
something
please.
to that? Sometimes we talk about these abstract things called exchanges, and you don't necessarily get a good feel for what we're really talking about. So if I could just take a minute and just describe a vision of what an exchange is. Think of it as a new storefront, physical, virtual. Does anybody remember Medicare Part D? Like, I have an 85-year-old father-in-law that had like 87 choices to make about which drug benefit to choose. Well, exchanges are going to be Medicare Part D on steroids, unless we figure it out. And there are best practices. There are 5 states that are really looking at a much better model. People think in groups of 3. You can handle 3 choices. It's hard to handle 80 choices. So think of it, you're going on a cruise ship. The exchange is going to be set up on the Olympics. Not to be political, that's where it came from. Gold, silver, bronze, platinum. So these are the decks on the ship. Which deck would you like to be on? Depending on the deck, it's going to cost different amounts of money, and your subsidies are going to be different. Now, once you pick your deck, then now we go horizontally on which kind of room you want on that deck. Some are going to offer, we'll get a free bottle of champagne if you go with us. And you can imagine introducing consumers to what could be a very empowered position to make choices, but they're not going to be able to do that on their own unless we first think about a way to organize it, to Kevin's point, that helps people get to a place that's about improving health, not just getting through some application because I have to do it or the IRS is going to come after me. And I just think that's a whole nother level of conversation that hasn't even started in our community and probably most communities. So I just think that's a real practical way to look at it.
Sure. Mr. McHugh, you wanted to jump in on this?
Yeah, in addition to supporting everything else the panelists say, I'd point out 3 different things that I've heard discussion about. One of those is that the law does require states to establish exchanges, or if they can't, the federal government will do it. What the law does not do is compel insurance companies to deal with the exchanges. There has to be some give and play here. People have to do business with the exchange for the exchange idea to work. And there is a general sense, I believe, or so I've heard, among insurance companies, they'd rather do business with who they know, which are the states, than with this distant federal government who theoretically knows very little about the day in, day out issues in that particular state. So I think to make these exchanges work best and to get businesses that are going to be providing the plans to those exchanges, I think it's better to do it at the state level. I think that's a practical point. The second point that I can say, because I'm in Washington, is there's almost nothing the federal government does efficiently. And if they're going to get their hands on this, not knowing anything about it, it's probably not going to be an outcome we'll all be proud of. And then the third issue, which is maybe not worth getting into too much yet, but there is a technical issue lurking in the woods here about the exchanges relating to the subsidies. There is an argument afoot now that the way the statute was written, there's a suggestion that people within states are not entitled to the subsidies, which are the monies the federal government will give them to buy insurance, if the state does not establish the exchange. So if a state does not establish the exchange and the federal government comes in, this argument would say that none of the individuals within that state that otherwise would be entitled to this leg up to pay for their policies would get it if it was a federal-run exchange rather than a state exchange. It may be a glitch in how, well, it is a glitch in how the statute is written. The federal government so far is kind of trying to sweep it under the rug. They may be successful at that, they may not, but it would probably be better if we don't have to get into that. So from that point of view, I would argue it's better that the states do it as well.
Just to quickly follow up, I mean, do the exchanges have a role in terms of helping you achieve your overall goal of helping to drive down costs? I mean, obviously, it's been well reported that costs on the front end are going to go up with this new law, but would the exchange actually help by introducing more choices, more competition and options?
I'd have to answer that with I don't know. I'm not entirely sure, nor do I think anyone is entirely sure exactly what we'll get with an exchange. I think, as I referenced at my opening comments, I think fundamentally the challenge is that we are operating within a fairly antiquated payment and delivery model that is built off of a very isolated way of thinking about and providing health care, when in fact, given the complexity of health care, it is a team-based sport. And we need to adjust what we're doing to allow for the kind of collaboration, the kind of integration that is necessary to achieve the efficiencies that we know we need to achieve. The simple fact of the matter is, all of us recognize that we cannot afford the rates of increase that we see happening with the cost of health care in this country year after year after year. But I think that the solutions, the answers to how we achieve the change that we all see being needed is best accomplished by those who are engaged in healthcare delivery now. And I think that is partnerships, again, between the providers, the hospitals, the physicians, as well as the payers, the employers, and policymakers in our own state. And I think that together we can address this issue. We can bring some integration to a highly fragmented healthcare delivery system.
Reginald, thank you very much. Sure. If you'd give Reginald a hand for his leadership on this, thank you very much. Okay, it's audience participation time. I'm Mark Pilkington with Cardinal Health, and on behalf of my colleagues from Cardinal Health, thank you for allowing us to be here today, and participate with this panel. We always leave time for Q&A at the end of these sessions. CMC records all of its forums for televised broadcast on ONN, so if you come up to the microphone, you might be on television, so be careful about that. And they're also streaming on CMC's website and the Metropolitan, the Cumberland Metropolitan Library website. We have a speaker here. I think this is the only one I see is right here. So if you've got a question, please step up and be courteous, of course. Try to be succinct. We only have about 15 minutes or so. Please keep the editorializing to a minimum and get to your question. And let us know your name, please, and your affiliation. And if you want to direct the question to a specific panelist, please do so. Yes, sir, first question.
Yes, my name is John McKnight, and probably should put this out there right up front. I don't know how to work my cell phone any better than I understand my health care, so
Your
not really
affiliation,
the sharpest stick in the stack.
Your affiliation, please?
My affiliation?
Yes. Who are you with?
Well, I work for Wright's Auto Body. It's
Okay,
a
cool.
collision repair center here in Columbus, and it is
Great.
a small family-owned business
Thank you.
that I've worked for about 20 years, and that's kind of at the root of my question.
Okay.
There's a lot of people out there that I've heard say that the Healthcare Reform Act is going to cost small businesses and small business owners a lot of money, and so this question really appeals to the cost more than the coverage. I've seen my healthcare costs rise year after year, as well as my employer's healthcare costs rise. Is there some inherent aspect of the Reform Act that I don't see or am not aware of that is going to cause an increase in the cost of healthcare from the employers more so than they're likely to see, should we have just stayed the course without the Reform Act?
Mr. Lutterjung, is that something that, yeah, you knew I was going to swing this one?
Thank you.
Didn't you? Yeah.
That's a great question. Here, beyond the exchanges, the Healthcare Reform Act has a provision called minimum loss ratio. What that means is that health plans are required to spend at least either 80 cents on the premium dollar or 85 cents on the premium dollar, depending on the size of the employer group. Now, so there, if we charge too much, so this is the thinking. See, this is a problem going off script. This is the thinking of the regulators, that the way to control cost is the health plans are making too much money, so we can compel them to spend a certain amount, a minimum amount, 85 cents on the dollar on health care. The problem is we're already spending more than that in aggregate, and you can think of the other aspects of the health plan. What is going to happen is that more people with higher costs, who are the uninsured population, with what many experts would suggest there's pent-up demand for health care services within this population, and there is not going to be underwriting. There's a thing called guaranteed issue and community rating that everybody will pay. So the folks within the system today we're all going to have to pay for the insurance of the others who will be joining the health system tomorrow, and it's likely that that's going to be even more inflationary than the current cost of commercial health insurance. So, to the employers. So it's not speaking to what, I'm sorry?
Yes, let's, if we could, did we answer your question, sir?
Give it a good shot.
Gave it a good shot. Thank you. Thank you. Yes, ma'am.
Hi, I'm Judy Huang. I work with a contract manufacturer in the medical device area. So I know with the hospitals, with the cost component that you talked about, there's going to be a lot of pressure with new patients, cost factors and lowering of the cost factors. And I know from the device side, from distributors like Cardinal and GPOs and the costs involved, I wondered what does that look like for some of the equipment or the disposables that are going to be used within the hospital system?
Sure. It's a very, very good question, and an interesting one, because I don't think the answer consistently ends up being that we don't purchase or make available technology. I think we have looked very closely at certain diagnosis types, and what we have found when we've looked at those diagnoses, we'll take, for example, joint replacement, and we've looked very closely within our integrated network. Let me back up a step or two. You know, I think part of the solution that I was referencing is the kind of program that we're developing to drive this transformation from volume to value. And what we've done is we've brought together physicians and other care providers, along with technical experts and other folks who are very knowledgeable, to look at the facts on the ground and say, what is the most effective way that we can care for our patients comprehensively? So that if we're looking at a patient who needs a joint replacement, how can we understand how to give them the best result at the end of the day and do so for the lowest total cost of care? If we can do that, at the end of the day, we're all going to be in a much better place. Whether we're talking about patients who are on Medicaid or patients who are with Medical Mutual. Now, what have we found in beginning to do that work? Well, there's actually, over the course of the past decade, because of considerable interest in quality within hospitals, incredible alignment among physicians in how they practice at the point of care in the hospital when you have your surgery. So their surgical outcomes and so forth are very closely aligned. There's very little variation there. Where the variation seems to come is much less with device selection. And by the way, we had hoped that that would be the answer because that's a lot simpler. We can say, oh, doctor, you're buying a much too expensive device. You need to go with device B. But that's not what we have been finding. Instead, what we're finding is it's the comprehensive care from before they ever come in to have their surgery to after they're done with their surgery and in rehab. And that we need to look at an episode of surgery as something that starts months before you ever go into the operating room and months after you leave the operating room, and think comprehensively about how are we going to deliver that care, again, with a goal of which practices will give us the best outcome and result, at the end of the day, the total package being the least expensive.
Thank you, Doctor. Yes, ma'am. We have time for maybe we have three questioners standing, so we'll get to these. Oh, two. We have two. Yes, ma'am.
Hello, I'm Joey Thomas, and I'm wondering, will this act affect those of us who are retired and already are on an insurance, a medical insurance policy? I'm thinking especially of STRS and PERS. Yes or no?
Anyone feel qualified to answer that question?
I'll jump in.
Okay.
Well, we really have 5 categories of how people are eligible. You know, Medicare, Medicaid, commercial, VA, self-pay uninsured. And so the Affordable Care Act adds some nice benefits to Medicare. So Medicare is not as directly impacted as Medicaid and commercial would be. So depending upon the contracts that those type of organizations have, but beyond the Affordable Care Act, it kind of gets to what we've been talking about. It also is, what are those employers or purchasers doing to make their care more sustainable, to make the cost more sustainable? And there's a lot of changes going on around value-based benefit design. So instead of saying, well, we're going to have these benefits designed like they have been for the last 20 or 30 years, we're going to start differentiating benefits to say, these are services that have higher value, and we should make those less costly to pursue. And these are services that have poor value, and consumers need to pay a bigger chunk of the freight on that, not taking choice away from consumers, but helping consumers understand that those things that you want don't necessarily indicate that they're going to be that helpful to you. And I think that's where you're going to see some of the changes happening in a relationship with the people that purchase your health care?
Well, in other words, it would be up to the provider. Let's say Medical Mutual, which I happen to have. The federal government will not come in there and say you have to have thus and so, even though you already have an insurance with this act.
Sure. And you might be able, there are certain things that self-funded groups like the retirement system is that you're excluded from in terms of the regulation. There are a few things that will impact self-funded plans. But by and large, self-funded groups are able to continue to select the kinds of benefits that you choose to pay for.
The act ultimately requires employers to have what they call minimum essential benefits, and there is some federal government involvement in defining that. But when you're employed by a state employer basis, basically the act, at least I understand it, is essentially going to take the position that whatever the state says is okay will be okay. You won't be seeing the federal government stepping in on the state level and telling states what to do. There's some constitutional issues as to whether they can even do that. But when you're moving away from a state employer to a normal private employer in the context of retirement, I think there is going to be a trend and potentially a rapid trend for employers to move away from retiree medical coverage generally, I think. This act encourages employers for the various reasons to do that, and to do that as soon as 2014, because in theory, the exchanges will be made available to those people. There are there are accounting benefits for employers to jettison those programs. So the delivery mode for retirees in the private context, if my guess is correct, I think we're going to see tremendous changes over a not too distant future.
Thank you. We have come to the end, but we want to get our last question in, sir.
I'm Dr. Tom Williams, retired cardiac surgeon. My affiliations are with OSU and Ohio Health. Is there any future for a $10,000 deductible with an HSA for young people?
Who wants to field that one? That's pretty wide swath there. Anyone feel comfortable with that?
What's important with the high deductible health plan is to arm people with the tools and the information and the access to the services they need when they need them. There's a theory, a behavioral economic theory, that high deductible health plans actually discourage people from getting the kinds of services they need when they need them. We talked about value-based benefits here earlier. There's a lot of work being done in the field of suggesting that this set of services is higher value than this set of services. Can we work on better coordinating the benefits so that members, so that beneficiaries can get access and don't have economic hurdles or obstacles to getting the services that they need? If we can align those with the provider reimbursement piece, like we're working on with Ohio Health right now, taking a population health approach, if we can align and have our providers working on those same sets of services, high-value services, we can start to hopefully simplify the delivery system for our members, eliminate the kind of confusion of, can I afford it? My doctor's telling me one thing, my health plan benefit is another thing, and we can perhaps improve the experience and the access to the important benefits that members have for their health care services. So a long-winded answer to a simple question, I think the most significant component of that question is who can afford and how do you afford the first $10,000 of your health care when you need it?
I think it's a very astute question. I'll just add one thing to your good comments. It's very clear that personal accountability for wellness and prevention is going to be key to population health management, and especially health management that achieves a lower total cost of care. My one concern about a high deductible plan of that magnitude is that it would in fact discourage young people who might have a condition which, if there's an intervention early enough, could result in the long run in substantial cost reductions for society.
We're going to take the privilege of one last comment with the guy who started our presentation. Thank you for your participation. Rich is going to close right after.
I just have one comment on your question. From a technical standpoint, is I think it's very problematic, and the reason I think it is because those individuals have to get minimum essential coverage, or else they have to pay those penalties for not doing so. The way I think the government is now viewing what minimum essential benefits coverage must be likely does not include those kinds of programs, whether they're good or bad otherwise in the abstract. And to the extent they don't, individuals who think those are what they need to have may be looking down the barrel of having that along with the penalty they have to pay for not having minimum essential coverage. That makes it problematic.
Well, first of all, thank you, Mark. And obviously, I'm going to state the obvious. This transformation is a real work in progress with an emphasis on work. Would you all come back in about a year? And maybe the year after that as well. It's been terrific, and I want to thank all of them. Before we leave, please remember to make reservations for next week's forum on education reform. You can continue this conversation with these gentlemen out in the lobby after our program. Once more, thank you, Ohio Health, Cardinal Health, and Porter Wright, Rich, Kevin, Bruce, and Jeff. Thank you all.